Okay, starting off with a brief introduction of what Ollier's disease is. Ollier's disease is defined as a non-heritable dysplasia cartilage characterized by multiple enchondromas with a prevalence of 1 in 100,000. The clinical presentation of Ollier's disease typically presents with symptoms of bone pain, palpable nodules of the extremities, discrepancy in limb lengths, and bone fractures. So tumors such as cholangiocarcinoma, pituitary adenomas, juvenile granulosa tumors, and gliomas, they tend to develop in about 50% cases of Ollier's disease. And also, gliomas are in particular frequent in patients with Ollier's disease. And for astrocytomas are the most prevalent type of central nervous system tumor associated with Ollier's disease. And just a brief overview of what an astrocytoma is. An astrocytoma is a growth starting in the astrocytes, which play a regulatory role in the brain function located in the brain or spinal cord. So the main focus of our case report was to address what is the prevalence of brain tumors, specifically astrocytomas associated with Ollier's disease, and is there a particular reason for this prevalence?
So now onto our case description. We had a 21-year-old male who presented to the ER with seizure-like symptoms, and it approximately lasted 3 minutes. He had a known history of Ollier's disease and had previous surgical interventions to remove the multiple enchondromas on his hands bilaterally, and his neurological evaluation was normal. His vitals were stable, his CBC was normal, and his CMP showed a slight elevation of lactic acid and then a slight elevation of glucose and then a decreased bicarbonate level. Imaging was ordered. Here we have a CT in the axial view, and you can see this area of low density on the patient left side. And this is in the left anterior aspect of the external capsule, and it extends to the anterior insular cortex and frontal white matter. It measured 4.3 by 3 centimeters, and it was suspected to be an infarct or a mass. And then an MRI was ordered as well in the frontal and transverse views. Here we have the frontal view, and you can see in the same area, you see that low density on the left side, and they were suspected to be low-grade gliomas. And here are a couple more images of the MRIs. Here on the left, we have the transverse view with contrast and the same insular or the same area of low density, and then on the right without contrast. So our patient was discharged with a prescription of Keppra for the seizure management, and then he was recommended to follow up in an outpatient clinic for biopsy of the masses, and it was found that they were grade 2 astrocytomas. He underwent chemotherapy and resection and was also started on Vimpat for seizure management. And then additionally, he was started on Tibsovo to prevent the progression of the astrocytomas. So just to recap a little bit, Ollier's disease presents with multiple enchondromas and in rare cases, a variety of CNS neoplasms. And to our knowledge, there are only 12 cases of Ollier's disease presenting with these grade 2 astrocytomas, including the present case today. So here we have a chart just describing the most common sites for astrocytoma involvement, and at 38% is the frontal lobe, at 19% includes the brainstem and the insular cortex, and then 14% is the temporal, and then 10% was a few other regions in the brain. And I do want to note that some of them were multifocal, so they kind of span different areas of the brain at once. All right, and here we have the common signs and symptoms that presented in these 12 cases. So we had seizures, headaches, cranial nerve palsies and deficits, and motor disturbances. And headaches were the most common symptom. However, they were very nonspecific. So the ones that were more specific to the grade 2 astrocytomas were cranial nerve palsies and deficits. So the patients that were diagnosed with Ollier's disease, they were diagnosed very early in childhood, and then much later in life, they were diagnosed with the astrocytoma. It was found that there was a 20.54-year difference between these diagnoses. We found a study published on brain gliomas that stated out of 31 patients, 15 were alive, 3 were deceased, and the rest of the patients had an unknown outcome. And the interventions that these patients had include craniotomy, radiotherapy, and chemotherapy. And the ones that were not mentioned had unknown outcomes. So the average survival rate after diagnosis of astrocytoma in relation to Ollier's disease is 3.53 years. And with native astrocytomas, it's 20.5 months. So some limitations of our case report: the prognosis of Ollier's disease is not well defined with the brain gliomas because presenting with the gliomas is very rare. So that means that there's not enough data to support a clear mortality rate, quality of life, or prognosis in these patients with the brain gliomas.
So moving on with the discussion, we're going to discuss how IDH mutations can sort of link Ollier's disease with astrocytomas. So with developing research techniques, it is found that mutations in the isocitrate dehydrogenase 1, the IDH1 gene, are prevalent in both enchondromas and gliomas. These patients with Ollier's disease are more prone to malignancies in other regions of the body due to this somatic IDH mosaicism. And of those with Ollier's disease, around 81% will have shown mutations in the IDH1 or IDH2 genes. This IDH1 mutation is also seen up to 71% of grade 2 and grade 3 gliomas. So there does seem to be a bit of a correlation between the two. And in this case specifically, Ollier's disease caused the formation of a grade 2 astrocytoma. A grade 2 astrocytoma is defined as a slow-growing, diffuse glioma with an IDH1 or IDH2 mutations. This most likely has TP53 or ATRX mutations without a 1p19q codeletion. So these molecular features typically present as a strong TP53 immunoreactivity and a loss of ATRX expression. So for TP53 in particular, mutations contribute to the dominant negative inhibition of a wild-type TP53 with pro-apoptotic function. So while TP53 mutations are common, having an over a 50% prevalence in human cancers, they seem to be especially prevalent in patients with Ollier's disease and gliomas. And in a 2020 study, 5 out of 6 patients who had Ollier's disease had this TP53 expression. As for ATRX mutations, they contribute to the abnormal maintenance in telomeres, leading to the alternative lengthening of telomeres. So while these pathways like ATRX are common in gliomas, 80% of them are being detected in secondary gliomas, and ATRX mutations tend to be specific to astrocytic tumors carrying the IDH1 and IDH2 mutations. So these ATRX and TP53 mutations may play a key role in explaining the development of gliomas, specifically astrocytomas in patients with Ollier's disease. IDH mutations, being one of the earliest oncogenic events in a majority of low-grade gliomas, are sufficient enough to induce enchondromas in animal trials. However, in human trials, IDH mutations alone have not been sufficient enough to induce gliomas and require additional alterations like the ATRX and TP53. This could elucidate why enchondromas appear more before gliomas in patients with Ollier's disease and justify the importance of regular cerebral MRI screens and the follow-up appointments of patients with Ollier's disease. And on the right here, we just have a photo emphasizing this fact. The patients with glioma precursor cells, if they have the mutant type IDH1 as well as the TP53 mutation and the ATRX loss, they are more likely to develop grade 2 astrocytomas and grade 3 astrocytomas. So moving on to our conclusions, we discussed a 21-year-old male with a known history of Ollier's disease who developed a grade 2 astrocytoma in the insular cortex in the frontal lobe of the brain. Multiple neoplasms are found and treated with chemotherapy and resection. We determined that IDH mutations are strongly correlated with the grade 2 gliomas and one of the earliest oncogenic events in most low-grade gliomas. Furthermore, ATRX and TP53 mutations are highly associated with astrocytomas and are required to induce gliomas in addition to the predisposing IDH mutations. It is essential that practicing physicians be aware of the common signs and symptoms of a grade 2 astrocytoma in patients with Ollier's disease. These symptoms include seizures, headaches, motor and sensory changes, cranial nerve palsies, specifically involving vision and hearing. So from all this, our closing remarks are these signs and symptoms prove strong evidence that gliomas and other neurological deficits can be caused by Ollier's disease. The overwhelming majority of Ollier's disease patients are diagnosed with an astrocytoma only after these severe symptoms are present. And once the diagnosis of Ollier's disease is made, routine cranial MRI should be performed to catch early developing neoplasms to improve patient treatment, outcome, and quality of life.
So here are our references on the present slide and then the next slide as well. And we are open to any questions.